the first IPE webinar of 2022. We're super excited to get this kicked off. As you may or may not know, the School of Health Sciences was founded on the value of interprofessionalism, and this value is also included in our school mission, which is to develop leaders who are culturally competent and experts in interprofessional healthcare practices. So just super excited that we are focusing on this and that you all have the opportunity to participate in these webinars each month. So welcome. And now it's my pleasure to introduce to you Dr. Robin Geiger, who is our Director of Clinical and Collaborative Practice. And in this role, Dr. Geiger ensures interprofessional competency is integrated into all SHS programs, and she is also responsible for overseeing the IPE Advisory Committee and supports the initiatives brought forward by the chair of the Advisory Committee, as well as advances collaborative practice within and for the School of Health Sciences. Dr. Geiger?
Thank you so much, Dr. Jones. Hello, everyone. We're really excited for the months ahead and looking forward to some amazing presentations and webinars on interprofessional education. Tonight, I'm reminded of a quote that captured my attention from a student leader. Interprofessional education is an opportunity to not only change the way that we think about educating future health workers, but is an opportunity to step back and reconsider the traditional means of healthcare delivery. That what we're doing and what we're talking about is not just a change in educational practices, but a change in the culture of medicine and healthcare. I found that quote just timely and fitting for tonight's presentation. And with that, I'd like to introduce our moderator for this evening, Dr. Linda Mast. Dr. Linda Mast is a professor and chair of the School of Health Sciences Interprofessional Education Advisory Committee. Her healthcare administration experience includes senior executive positions in academic medical centers, hospitals, and as Chief Compliance Officer for the University of Chicago. Her academic experience includes academic leadership roles as Associate Dean and Program Directors for several universities, and new program and curriculum development in both traditional and face-to-face and online delivery. Interprofessional education and innovation in curriculum design for adult learners are her passions. And she has served as principal investigator for funded and published research in areas of interprofessional collaboration, self-directed learning, and competency-based education. She is a longtime member of AUPHA, member of JHAE editorial board, and Dr. Mast is a fellow in the American College of Medical Practice Executives and a veteran of the Army Nurse Corps. We're very excited that she is our chair of our IPE Advisory Committee and moderating tonight's webinar. Dr. Mast?
Thank you, Dr. Geiger. So one of the things that is really wonderful about interprofessional collaboration is that it gives us a chance to learn about, from, and with each other. So I hope that you will appreciate the introductions as really just a way to get to know each other. And I'll be introducing our panel presenters and Dr. Marshall, who's giving our wrap-up presentation tonight shortly. But I thought since it's the beginning of the year, I would take a few minutes to just give a quick overview of what interprofessional education is and interprofessional collaboration is about. And I just want to share a couple of slides. So just to give an overview about interprofessional education here at the School of Health Sciences, wanted to just start off with a well-known quote, probably most of you may have seen, or if not, this will be a good introduction. The World Health Organization highlights that interprofessional education occurs when two or more professions learn about, from, and with each other to enable effective collaboration. So that really frames everything the School of Health Sciences does. And in case you aren't familiar with IPEC, this is an organization to follow. It's the Interprofessional Education Collaborative. And just a little history about IPEC. They were founded in 2009 by 6 national associations of schools represented by dentistry, nursing, medicine, osteopathic medicine, pharmacy, and public health, with the intention to promote and encourage collaborative team-based care and improve patient outcomes. There were core competencies that were created by that team and to guide curriculum development across the professions. So those initial core competencies were published in 2011 and have been recently updated in 2016. And I will share the 2016 IPEC publication in the Commons in the IPE forum after our presentation so that you have that as a resource if you haven't seen it. So moving ahead, interprofessional education is actually becoming a domain of its own, and it's guided by those core competencies. And you'll see that those core competencies are reflected in our School of Health Sciences programs, and that's interprofessional teamwork, interprofessional communication, rules and responsibilities for collaborative practice, and then of course, values and ethics for interprofessional education. And so this diagram I just like to share. It's one of my favorites that really describes the interrelationship between interprofessional education and what interprofessional collaboration looks like in practice. And I'll share this also in the Commons so that you have this. There's a lot going on this diagram, but it's really useful because it really also underscores the influence of government policy and social and cultural values and how that shapes how collaboration works. And so our webinar speakers, that some of you have attended other programs. So our monthly webinar speakers share real world insights and examples of ways interprofessional collaboration benefits their organizations. And I think if you've attended some in the past, you also know that they really honestly share about the challenges that they have faced in leadership and fostering teamwork. And just a final comment, I hope that you'll mark your calendars to join us the 4th Thursday of every month at 6 p.m. Central for our future webinars. We try to keep it the same time so that you kind of can plan ahead. And next month on February 24th, our speaker will be Mr. Cooper Linton. He is the Associate Vice President of Duke University's Home Health, Hospice, and Infusion Services. He's a fantastic speaker, a lot of fun, and so knowledgeable. So I hope you won't miss it. And so without further ado, just with that framework to get us started, I am so excited to introduce our panelists today. And again, I hope you'll pay close attention to their bios because this is really going to help you to learn about them. Some of our panelists are fellow students and some are faculty. So it's just really nice to get to know more about individual presenters that are part of School of Health Sciences. And so the whole focus of our program tonight, interprofessional collaboration across the continuum, your path to career advancement and publication. This is really designed to give you kind of a perspective of interprofessional collaboration across the continuum from individual patient services, individual patient care, and then we'll broaden that out and we'll, our panelists also include the perspective of government organizations and how they collaborate with a variety of organizations. So we're going to really take you through that whole continuum. And each of our presenters will have a few minutes. They're going to kind of introduce their philosophy and their insights from their vast expertise. And then we'll encourage conversation. If you have questions, you can post them in the chat. And we hope to have a pretty dynamic Q&A with our panelists. And then we'll be wrapping up with a presentation from Dr. Marshall, and I will introduce her at the end of our panel presentation. So our panelists include Dr. Shedrick Shields. Dr. Shields is an assistant professor for the School of Health Sciences, Department of Nursing at North Central. And he holds a Bachelor of Science in Nursing from Florida State, a Master's of Science in Nursing from the University of South Alabama, and a Doctor of Philosophy in Nursing from the University of Phoenix. Dr. Shields has over 22 years of experience in nursing with extensive background in nursing education, nursing leadership, family practice, and primary care. He's an experienced nurse educator and has expertise in teaching and facilitating didactic and clinical courses for undergraduate and graduate students. Prior to joining North Central, he was a National Health Services Corporation scholarship recipient and provided primary care to underserved communities. Dr. Shields is a board certified nurse practitioner with board certification from the American Nurses Credentialing Center, ANCC. So we're delighted to have Dr. Shields on our panel. And another panel, our next panelist I want to introduce is Veronica Shake. Hello, Veronica. Veronica has been a registered nurse for 10 years with experience in telemetry, labor and delivery, outpatient clinic, and school-based nursing. Veronica has also precepted, worked as a charge nurse, taught as adjunct clinical faculty in an Associates of Nursing degree program, and participated in hospital-based shared governance groups. Veronica received her Associates of Science in Nursing degree from Los Angeles County College of Nursing and Allied Health, and her Bachelor of Science in Nursing with honors from University of Phoenix. Veronica is currently in NCU's Master of Science Nursing, Management, and Organizational Leadership program. Two highlights of her nursing career are using her Mandarin language skills and organizational leadership and helping Chinese patients successfully deliver their babies in participating in 2 medical missions to Zambia. It just sounds so fascinating. And Veronica is the proud aunt of 9 nieces and nephews under 8 years old and loves spending time with her family and teaching the next generation. Our next panelist is Deborah Illig, and she is a doctoral candidate from North Central University. Deborah Illig is Vice President of Clinical Effectiveness and Patient Safety for Adventist Healthcare. Adventist Healthcare is based in Gaithersburg, Maryland, and employs 6,200 people and provides healthcare for more than 400,000 individuals in their communities each year. Throughout her career as a nurse executive, Deborah has assumed leadership roles across the healthcare continuum. Her passion is hospice and palliative care. Deborah earned her MBA from Marymount University in Arlington, Virginia, and her BSN from Indiana University of Pennsylvania. She is a black belt in Lean Six Sigma with multiple certifications in healthcare quality, patient safety, and legal nurse consulting. Deborah is one of NCU's doctoral candidates in health administration. She is an avid horsewoman. Deborah resides in Maryland, horse country, with her husband and a menagerie of 4-legged family members. And our final panelist is Tabitha Myatt, and she is also a DHA student at North Central University. Tabitha has over 20 years of experience in health and human services. She currently works for the Centers for Medicare and Medicaid Services, CMS, in the Division of Program Operations. In her current role, Tabitha provides oversight for state Medicaid programs. She has served as a long-term care social worker, quality improvement specialist, program analyst, and manager. Tabitha is currently enrolled at North Central University in School of Health Sciences, working to obtain a DHA. She serves on the Student Advisory Committee and the Interprofessional Education Advisory Committee. Tabitha is committed to partnering with individuals within and outside healthcare industry to enhance innovative healthcare delivery practices and policies. Tabitha holds a master's in health services administration and a master's in public administration from Strayer University. She obtained a bachelor's of arts in psychology from North Carolina A&T State University. So please welcome our esteemed panelists, and we're going to start out with Dr. Shields, and we'll start from that individual patient perspective and then move broader with the rest of our panelists. So I'm very excited to hear from our panelists.
All right. Well, good afternoon to everybody, and it's certainly a pleasure of mine to be on a panel with such a diverse group with such a diverse background. Everybody's offering their unique perspective on IPE and collaboration throughout the continuum. My portion tonight is to really focus on the primary care perspective when we're talking about IPE and collaboration. As we all know, in healthcare, you can't function in silos and by yourself. We're all interdependent on each other and we need each other. So it's most important to establish those connections, of course, with your community members, family, and healthcare workers. In my particular line of work outside of academia, case managers and social workers are a lot of my first contacts with community members, as well as I deal a lot with home healthcare agencies, pharmacies, DME companies who provide, hospital beds, durable medical equipment, phlebotomy services, oxygen companies. There are so many different disciplines and so many different needs that need to be met when you're dealing with primary care out in communities. So you have to establish those types of connections in order to, provide high quality services to your patients. It's vital, of course, to establish this rapport with them so that, you can communicate when things are going wrong with patients and when things are going right. So IPE is certainly essential in that realm. Patient care, family also. You have to collaborate with the family. Let's not forget family and community members as well. Families are essential in getting patients in to see healthcare providers or individuals that need to handle their medical their needs. So let's not forget family and community in IPE as well, because they're essential. Reaching out to communities, especially communities that are underserved and communities that are not as health literate as others. They're essential as well if we want to, provide good quality services to everyone, and make sure that everyone has access to good quality services. So IPE is essential. Nurses are, of course, on the front lines of care most of the time. They usually wear many hats as case managers, social workers. They're kind of everywhere. And as we all know, I know the nurses at least know that we tend to be the gatekeepers for healthcare, getting them into the system as well as discharging them successfully out of the healthcare continuum. And it's a slippery slope, but establishing good community contacts, recognizing the importance of everyone in the continuum is essential. From your auxiliary staff to your DME companies, everybody plays a vital role when it comes to providing high quality care to patients. And we must all recognize and know the importance of everybody who's involved in the process. I can go way down a rabbit hole on primary care, but I'll leave it there if anybody has any questions for me, or we can move on to Veronica.
Thank you, Dr. Shields. Let's move on to Veronica, and then we can have kind of a dynamic conversation at the end with all the panelists. And appreciate that.
Mm-hmm.
Cool. Well, thank you. Like Dr. Mass said in my introduction, my name is Veronica Shake. And so I'll be talking about IPE more in the hospital setting. So at Silva Health Martinsville is where I do my clinical time, and we have a good example of that interprofessional collaboration. So by way of introduction, Silva Health is a full service acute care hospital in Southern Virginia. It employs over 700 people, including over 100 physicians and allied health professionals, and provides over 22 medical specialties. It's licensed for 220 beds and sees 30 to 40,000 patients annually, although probably with COVID, that number has increased significantly. We hold interdisciplinary team rounding, or IDTs, every day. During this time, the interprofessional team spends upwards of an hour discussing each patient's conditions, needs, discharge barriers, basically the whole plan of care. So they round, or they go on go over all patients in the unit minus behavioral health, but they do include the patients in the ED who are holding, who have already been admitted. The team looks at, so they kind of do the plan. So they look for the plan of the day, the plan of the stay, and the plan of the way, or the plan to get home. IDT wants the patient to meet the goals for during hospitalization, as well as figure out what to do to ensure they stay home after discharge, because that's, like Dr. Shields said, that continuum, that plan of care is important. Currently in our IDTs, we have the doctors, case management, dietary, pharmacy, PT, OT, and ST, or speech therapy. Those are the only specialties participating. So the doctor deals with treatment, case management is discharge placement and following up with their needs. Pharmacy does medication reconciliation, drug interactions, and making sure that there's no untoward effects that will bring the patient, either leave the patient in the hospital longer or bring them back post-discharge. And then dietary helps with nutrition and counseling. And the therapies work with the any physical, occupational, or speech therapy needs. Currently, the CNO or Chief Nursing Officer is the only part of the IDTs. There's no other, unfortunately, no other nurse manager, bedside nurse. There's no other nursing involved at this point. So studies show that the benefits of IDTs include being able to discuss patients in real time and collaboratively establish patient-centered goals, improvements in perceived teamwork, interdisciplinary communication and collaboration, and significant decreases to length of stay and 30-day mortality, as well as some hospital costs and adverse events. So for us, our system definitely has some benefits. Some of our drawbacks or things that we are that we could work on is that it's currently held in a room that is remote from patients. So the patient is not involved. Nursing is also not involved. And then it takes a lot of time. So things that we're working to address these issues we're working towards a geographic rounding and going to where the work happens or where the patient are. Studies show that conference room IDTs help with length of stay and decreased mortality, but they don't help with adverse events. And so moving to the bedside, the studies show that it doesn't have an impact on length of stay or 30-day readmission rates. However, it does help with 7-day readmission rates. It decreases them by 30%, and it can help with those adverse events. And then moving to the bedside would also help us bring in nursing, which as a nurse, I would love that because since nursing isn't involved right now, they don't always get the feedback to help with patient care in a timely manner. And so going to the World Health Organization, they note that higher functioning teams deliver high quality care, and patients perceive that health professionals who work together in teams are the most effective. So bringing that nursing component in makes the provider more effective, but it also helps the patient see that as well. And so then that helps bring in the nurse and it brings in the patient. Like Dr. Shields said, that rounds out the team of patient care, and it helps the patient is one of the most pivotal parts in making sure that there is the plan of care and compliance with the plan of care. So bringing them in to help make their goals and to help them know what's going on really makes a difference. So we're still working on that time commitment thing, but moving to a geographic rounding system would streamline efficiency. We wouldn't have to wait for the doctor to arrive because we'd be coming to them, and it would be focused on the patient more than anything else. So IDTs is definitely a helpful process, and it's got benefits for both the patient and provider. So, and we're working on improving that. So thank you. That's what I get to say about our process.
Thank you, Veronica, and really appreciate your kind of honest appraisal of opportunities for improvement. It's always so valuable to kind of hear what's been the best practice, best experiences, and where you're looking to move forward with even better approaches. And I haven't heard about plan the day, plan the state, plan the way. That's new to me. So That's very memorable, and thank you. And our next presenter is Deborah Illig, and welcome, Deborah.
Thank you, Dr. Mast. So before I get into some of my comments, I have at least one pair of observations. It is 7:25, and already I've made several notes. And I think that that's a testimony to how rich the expertise is that's represented here this evening, and certainly well beyond those of us gathered here tonight, whether it be faculty and or our fellow students. So what an exciting opportunity it is to be able to share some experiences. As we transition into a health system perspective of clinical service delivery, I just want to build in basically 3 lanes for your consideration as I cover some content this evening. The first is that of free from harm, creating a state, an environment, an effort, an infrastructure that focuses on delivering care at a level that is free from harm. The second is that of standardized clinical practice. And the third is that of high reliability. So in my role as a patient safety officer at a health system, as you can imagine, every aspect of the continuum has their own unique perspective. Within that aspect of the continuum, so too comes perspectives within each entity. And I think when Dr. Shields was speaking earlier, the one thing that I wrote right as he opened with his comments were the connections and the rapport, whether we're talking about those we serve, those who love them and support them, or those who actually are caring for them on a day-to-day basis. And so when I think about what Dr. Mast and others have commented on to this point, I think the interconnectedness and the rapport and the relationships that we have are just extremely valuable. In the domain of free from harm, we take a look at what we use as RL Datix for our adverse event reporting database. And we actually have a wonderful team along with our fellow patient safety officers who do 100% review of those RL events every day, with the exception of the weekends. And then certainly we pick up on that on Monday. But from there, which is really very much patient focused, we then begin to move through the scope and severity, a crosswalk for those of the national patient safety goals, any particular trends across our health system as illustrated by heat maps. And then we pivot into that interprofessional education and learning opportunity where we're discussing really what system-wide implications we have. The reason why that scope of work is so very important is, first and foremost, it's a patient safety domain and a key component of that role. But secondarily, it also feeds right into the second lane, which is that of standardized clinical practice. So we are working very hard in our health system to go upstream. I would not be surprised if others on this webinar this evening often wonder, why do we spend so much time downstream, and why are we always so reactive? And what is it that we could or should do to engage in concurrent review activities or be much more proactive, such that things like preliminary reviews and root cause analyses become less, and the systems reviews and designs become more the norm as opposed to maybe the exception. And so in that regard, our health system has just recently transitioned from standardized clinical practice as a key strategy, with a concentration on bundle compliance in central lines, indwelling urinary catheters, and ventilators, to something that is much more comprehensive, comprised of a component of purposeful hourly rounding, barcode medication administration, and ultimately post-surgical or procedural debriefs. What I'm hoping that you begin to see and hear as I move through these lanes is, at the end of the day, it is always, as Veronica and Dr. Shields have spoken about the patient at the core. But with each component of this webinar this evening, you begin to move up and then go across. So the last component that I have is that of high reliability, and just wanted to share with you all that we utilize the Leapfrog safety grade as our North Star. The CMS star rating quickly follows behind that. And then we continue on our Malcolm Baldrige National Quality Award journey. And what that has really compelled us to do is to recognize two things. Number one, it's not about the award. It's about the constant improvement as we continue to focus on both outcome and process measures. And equally as important, it's about these deeper relationships of among ourselves to concentrate on what our key charge is, what our mission is, and how we wrap our values around that, all in pursuit of a grander vision. So as I transition to Tabitha, I just want to leave you with a couple of thoughts, a couple of words, and I would be very curious to hear whether you consider these words to be barriers or whether you consider them to be facilitators. And so here's the list that I thought I would run by each of you to just contemplate and see where it goes when we have the conclusion of the presentations to maybe open some dialogue. And so this list is consisting of governance, optics, evidence, bias, and balance. So with that, Dr. Mast, thank you for the opportunity, and we can transition to Tabitha.
Thanks for those final thoughts there. Welcome, Tabitha. Tabitha's going to really take us to the federal level in collaborating across many organizations. So.
Wow, I am so impressed, my fellow panelists here. I was thinking on one track, and now I'm getting ready to go on another track. I'm telling you, it makes me want to get back and the day-to-day relations in the community with the foot soldiers. Working at the federal level, it's totally different now. Federal and state partnerships and community partnerships, that's whole stakeholder partnership, is something to relish in. It's a good feeling when you can come together and work collaboratively with stakeholders at a higher level, and it funnels down to the ground level, meaning our patients, meaning our families, meaning our physicians, our nurses. We work with so many individuals on a daily basis. Some days it's unreal, and especially nowadays with all the COVID, the pandemic, in addition to all the other health crises that's going on with the wildfires, the hurricanes, etc. So you can imagine. So I'm going to go here with this. When we look at collaboration and interprofessionalism throughout Health and Human Services, we at CMS partner with so many agencies. We partner with, children, ACF. We partner with state agencies. On a daily basis, I work with probably 5 states I know, assisting them with ensuring that their state Medicaid programs are in compliance with statutes, federal regulations, that, they're running them in accordance to all the guidelines. I mean, there's so many, to ensure that the quality of care is there, to ensure that the funding is there, to ensure that services are provided in a timely manner. You name it, we do it. So you can only imagine, from cost reporting. So the individuals that we work with physicians, we work with nurses, we work with pharmacists, we work with family members, we work with the patients themselves on the Medicare side, on the Medicaid side. And with our state partners, there's nurses there, there's doctors there. We run the gamut, all types of professionals. But when we get to the crux of the work, when it's time to really put our paper and pencils together, our pens together, our heads together, we come together in group meetings, and we actually work on products. We work on teams to look at policies, to really kind of, you know, peel the onion to better understand how we can make things more efficient, how we can make things better to improve on processes for the individuals that we're serving, that the states are serving. What can we do to include individuals in their care? You know, what could we do from the standpoint of a funding, you know, different mechanisms? We look at different grant programs. We look at rural health centers. What could we do in the rural communities to support the individuals in those areas? We look at all types of opportunities with different agencies. So we look at interagency fundings. We look at local social service departments. I can't say, you know, from the governor's office, we deal with, you know, different constituents on, you know, the commissioners. So we are engaged with so many different people at different levels. It's amazing. And the collaboration, I mean, the relationships that we build, we can't ask for any better relationships at this point to ensure, as Deborah mentioned, the patient safety. The funding is there, the support throughout the communities is there. And so I'll leave it there. I know we're running short on time. I could go deeper into it, but I want to have time so we can have some discussion around some of the key points and some of the points that all the other panelists brought up. And we still have Dr. Marshall to present as well before 8 o'clock.
Thank you, Tabitha. I was just really impressed with the commitment to collaboration at every level with everything that your organization touches, from individual patients and providers all the way to interagency. It's really interesting to hear that. So, you've all heard from our panelists, really different perspectives, and would love to hear if anyone has questions. I'd like to kind of keep this interactive. If anyone has a question, you could unmute yourself and feel free to ask. I'll give you a couple minutes. Does anyone have a particular question? I hope so.
I do, Dr. Mast.
Good.
I wanted to ask Veronica, she mentioned clinical rounds a number of times, and I wanted to ask her, as far as interprofessional clinical practice, are there different strategies for different nursing units? For example, is there a different round strategy for the emergency department versus an intensive care versus a medical unit?
There are some different strategies. The ER kind of, since the patient, so any inpatient patient, they get rounded on. The ER is a little bit different because they're not admitted yet. And so then those doctors kind of talk to case manager and they kind of work with those patients down there. The patients in the rest of the hospital, right now, it's kind of a pretty uniform because it's in a conference room. We don't go to see the patients. So it's kind of pretty uniform for each of the patients. I assume that once we start with the geographic rounding, that it will kind of then specialize to each unit, that the things that there will be some not baseline, but some uniformity between them, because pharmacy will still be a part of it, case management, PTOT, those core people will still be part of it. So in that way, there will be uniformity, but it might be just a little bit tailored between med-surg, between ICU, between telemetry, and so on.
Was it hard to get buy-in from those other professionals, pharmacy, OT, PT, SLP? Was it hard to get their buy-in to do this type of interprofessional collaboration?
So the IDTs started before I attended. So I don't know how the original development or the baby steps of that. I assume that probably that there was probably a little bit of pushback, just because that's what happens with any new innovative change. But so far it seems that everybody is on board and everybody is invested in checking with each patient to make sure that the patient's needs are met.
Great. And you involve family in those patient rounds?
Currently, not so much. That's one thing that we are working on, is so that once we get to the bedside, we'll be able to increase that nurse and that patient participation.
Great. Thanks, Veronica. Good job.
Thanks.
Hi, Brenda. Hi, Deborah. This is for you. I know that in your role that you have the unique opportunity to work across cultures.
Mm-hmm.
And how does that affect what you do? You know, we talk about interprofessional collaboration, and when you consider applying the model across cultures, across ethnic groups, how does that work? What tips would you give? What observations would you share?
Yeah, so Dr. Marshall, great question. First and foremost, it's so ironic that this is a question that you're raising, because while we always stand as one as a health system, but the reality is that there are unique cultures and attributes to every single unit, every single entity, every single setting across our health system. And so a couple of things. Number one, when we're really speaking about diversity and inclusion, I will tell you, we have made a significant investment and a very deliberate effort to structure that division, for lack of better words, and the resources around it. I will be very transparent and say we have a long ways to go. We are outside of the nation's capital. So as you can imagine, you know, there's a lot of diversity for those that we serve. But the beautiful thing is that our workforce is equally as diverse. So we learn, number one, to be as sensitive as we possibly can. Number two, we are working, as I said, to formalize not only a level of awareness, but leveraging some of the expertise that our team members are bringing. When Veronica was talking about interdisciplinary team rounding and things of that sort, it is absolutely amazing what our team members bring to the table when we're dealing with cultural diversity. They have gotten extremely bold and fortunately very vocal about this particular treatment plan or this particular approach will not work for this particular patient or this particular family. We need to slow down long enough to listen to that. Because when we make mistakes that, or I will even say poor decisions that infringe upon cultural aspects of a treatment plan, recovery from that is extremely, extremely difficult. And so we are working in that regard. We also have a key component of mission integration. You'll actually hear a colleague, Ann Rhoda, speak to all of us, I believe, in the month of April, and she will talk somewhat about that. But we are on a journey, Dr. Marshall. We have not figured it all out, but we do believe that, you know, with at least acknowledging that there's a potential gap there and then setting it as a priority and then resourcing it is half the battle. The other half of the battle is, do people want to engage in the learning opportunities that frankly each interaction affords them? And so some areas do it better than others. Some populations demand it more than others. And I think that, you know, the industry is learning together.
Well, you know, when I put together my, hopefully 5 minutes, no more, I thought about you, and I thought about the rich environment you have, and I thought, oh, Deborah has the richest environment for publishing and making presentations I can think of at the moment. So,
Thank you, Dr. Marshall.
you were one of my inspirations when I put this together.
Oh, wow. Thank you so much.
You're welcome.
Thanks for that question, Dr. Marshall. And Chrissy, I know you had a question, and I want to make sure we have time for that.
I think I got it all off mute now. I put it in the chat as well, but as IDTs or interdisciplinary teams are becoming much more vogue and, you know, a more common practice, one of the things I found is that not all voices are given the same weight, and there's a tendency to frequently defer to quote unquote the highest degree in the room. So I'm just curious from this group, how are some of the strategies that you may be employing to encourage that equal voice, whether your IDT involves drivers to, you know, whomever may be part of it, because it's amazing sometimes what a driver or the custodial care might be able to say that the rest of us would not catch, but it's lost in the my voice isn't as important as the person over there with XYZ degree.
If I can hop on, I think the one thing with that is it kind of goes back to what we were talking about, is that buy-in from everybody in the group, especially those leaders, so that then those highest degrees are those ones that often take that lead, that they get that buy-in to say, no, we're actually a team. We're not a hierarchy. We're not one voice is more important or more involved than another voice, but it's actually getting that communication. I think one thing that you can do is do mock codes or mock collaborative events, so that then it's not just we're going to IDTs and this is when we collaborate and then we don't do it anywhere else, but you actually create other opportunities for that interprofessional communication, collaboration, and getting to know each other, so that then you can actually trust those other team members to work together.
I think, Chrissy, too, for us at CMS, at least when we take rotation on survey and cert teams, when we go out to the states or, you know, different pay sites per chance, we rotate. You know, we'll rotate out team members to encourage that, you know, support of other team members, to let them champion the team at some certain point in time. So that helps also. And then we allow the autonomy of different team members to rotate depending on what's going on and what activities are going on across the agency.
Okay, that's good as well. Chris, it could be something as simple as asking them, include them. You know, when I see patients or I have home health aides in the homes of my patients, ask them, so what do you think? What do you think we should do? You know, what foods do you think we should add to their diet? You know, how do you think we should, you know, help this patient better get in and out of their bed? Ask them, be more inclusionary with the individuals, make them feel more comfortable in asking you and providing their insights. So I think it goes back to that word rapport. Make them feel comfortable. Ask them their opinion. You know, make them more that way. You know, if you start asking, making them more comfortable, then they'll start offering information more freely, and you'll get a lot more of what you need to care for your patients and to make sure staff is happy.
Absolutely, completely agree. I'm just thinking of, you know, as all of us are leaders in that idea of the things that we don't necessarily think about, just being maybe cognizant even as ourselves as we go into those rooms as the leaders to say, and what about your opinion? I don't hear from you very often, and, you know, to elicit and make a space for, because we can say that we're all doing IDTs till the cows come home, but unless we actually have that true participation and give that space and voice for somebody who may not have been as brave to say, oh yes, well, I have an opinion and I may not have this degree, or I may not be, you know, clinical. For me, I'm not a clinician, but I'll be the first one to say, and here's, you know, what I see from my side of the world, but also making sure that I have created a space for that next person to me, or 2 spots down or 2 squares over on the Zoom to have that same opportunity.
Agreed.
And
Really
Chrissy,
great question. So what I'd like to do is I'd like to continue our conversation in the Commons. This has been such a fabulous conversation. And I also want to revisit what Deborah asked us about, whether it's a barrier or a facilitator, those topics: governance, optics, evidence, bias, and balance. So I'm going to look for some follow-up. Let's continue our conversation in the Commons. Want to make sure we have time for Dr. Marshall here at the end. Thank you everyone for the great presentations, our panel, and the great engagement, great questions. So moving on, I want to make sure we have time for Dr. Marshall. And I want to introduce Dr. Marshall to those of you that may not have met her before. Dr. Brenda Stevenson Marshall is a core part-time professor and subject matter expert for the School of Health Sciences. She holds an MPH in Policy Planning and Regulation from UC Berkeley and an MAE in Applied Economics from the University of Michigan, Ann Arbor, and a PhD in Health Services Organization and Policy from the University of Michigan. And so Dr. Stevenson Marshall is a health policy analyst, health economist, and health strategist with employment and research experience in public and private health systems. The past 29 years were spent in academic positions ranging from program director for an MBA in healthcare and an MPH to associate dean to academic dean for 2 different liberal arts universities. Her most immediate past position, from which she retired in 2018, was that of inaugural dean for the School of Nursing and Human Physiology at Gonzaga University in Spokane, Washington. She surrendered her tenured position as full professor of public health to assume the most immediate past position. And so Dr. Marshall's actually very modest. Her accomplishments are so much more than what we've covered here, but she's going to talk to us about hopefully inspiring you to think about publication and some other professional activities. So I'm going to pull up her slides for us. Oops.
So I'd like to say, in the interest of time when you're starting this, that the slides are available to anyone who wants them. This is part elevator presentation, part practical information. And it really stems from the journey that I had to take from corporate America in healthcare to academia to integrating the two. So this is about publications and presentations and how you can see that this is a very important and essential way to build your career. So we need publications and presentations. They're a necessary component of your career enhancement portfolio. All of us have to build a career profile. Having a degree or not having a degree, we need to have that identity. We need to establish our academic practitioner credentials. And we do this for a simple reason: to create options for ourselves. Next slide. I have 4 no's and 2 why's for you. I've given you one of the whys. Here is the first no. Know your stuff. Do not bluff. Do not, at any cost, try to exaggerate your knowledge, your profession, your work level or expertise, if that is surely going to be a real deterrent. We can move on. Next slide. Know that the whole is greater than the sum of its parts. It's very difficult, unless you are an absolutely amazing individual, to publish by yourself, to make presentations on your own. So know that the whole is greater than the sum of its parts. And this is what we're doing here. This is what this is all about. Join or create an IP team for publishing and presentation. All of us operate at one level on the pyramid of knowledge. Let's take this opportunity to grow our knowledge base and increase our publication and presentation base by creating an IP team or joining an IP team. By so doing, you can develop creative ways to publish or present. We all bring something unique to the table. We have Dr. Shields, who's a nurse practitioner, and we have Veronica, who has extensive experience in other areas, and Deborah, who is an executive. Just think of the richness they bring to a collaborative effort to present or publish. The next slide. IP teams, you can network and find other professionals who share your interests and career goals. Most important, working together, you can develop a strategic plan for submitting manuscripts and developing presentations. Just think of the journals among the three that I've mentioned. You can submit to any one of them. You can develop manuscripts from not just one perspective, but 3 perspectives or more. I speak from personal experience when I say that I would not have been tenured as a full professor had I tried to do that as a single publisher or a single presenter. Next slide. Know your venues. Join professional organizations and publish in professional journals. With a team you have, how many more professional organizations? How many more professional journals? I chose this as an example because we support and advocate for the American College of Healthcare Executives. So I took a screenshot of the Journal of Healthcare Management and simply inserted it here. This is professional organizations are one of the best pathways to presenting your work in either publications or presentation formats. Join as a student, it's less expensive. Take advantage of every opportunity to publish, to present, to network. What is important here is that every professional organization, or almost every professional organization, has its own journal. Go to the web page, and invariably they have instructions for authors. They will tell you, we welcome presentations, a letter to the editor, commentaries. There's much more to be said than just a manuscript. That's one example. There are so many opportunities to have your voice heard, and voice heard through an organization and the journal. Next page or next slide. Next slide. Oh, maybe there we go. Thank you, Linda. So this is simply a starter list of professional organizations and the associated journals. And to the nurses, I know there are so many more. I know there is a journal for nurse practitioners. I know there is a journal for every aspect of nursing. I simply chose this as the example. And I would like to comment on the very last entry here, the Journal of Public Health Management and Practice. This is a journal that is not associated with any one profession, but a number of professions. And what is unique here is they have what they call a JPHMP Direct, and it's a blog site. And this is another opportunity to have your voice heard. I have to admit that I'm personally invested in this because I'm currently directing one of the blog sites, and so the one for health administration. But it's a wonderful opportunity. If you have something you want to say, we've heard about the lack of literacy in finance, opportunity to speak out there that can later be a publication. So I encourage you to think, perhaps starting small. Think of a blog or a podcast that can easily be translated into a manuscript or possibly a more formal presentation. And the final slide. Know that patience is a virtue and success has many faces. Sometimes the most important thing that can happen to you is to get a letter that says revise and resubmit. Sometimes by so doing, you learn so much. Or your poster presentation is not accepted at your first choice. That's fine. If you have a strategic plan, you should have a list of organizations, a list of events. And you say, fine, if my presentation isn't acceptable here, we'll try somewhere else. You've got to be resilient. And why? Why is this so important? Next slide. We're all on this journey, or I'm no longer, I'm retired, I'm part-time. So you're on this journey so you can reach the light and ascend to the towers at the end of this pathway. I really like this slide. It was, to me, just so inspirational. You need to create and maintain an academic and professional footprint that leads to career options. If you have career options, you're in charge. I think there isn't anything, speaking from 30 years of being involved in healthcare at many different levels, having options means you're in charge, and there isn't anything more empowering. And I think when you're empowered at that level, you really do make very good contributions. There's one more slide, right? So if you have questions, I'm happy to answer them. I'm happy to entertain emails. And I say here what any researcher would say. I may have answers, or we'll have to do additional research. So, thank you for the opportunity. I find frequently when I speak with students and mentor students and counsel them, that this is an area where there really is a need for additional coaching. That this is such an important part of your career development. And you need to start it now. Don't wait until you earn your degree. I think one of the saddest commentaries I saw in the Commons was a plea from a graduate who said, "Will someone help me learn to publish?" And my heart just went out to that person. She said she didn't know how. She had the degree, but she didn't know how to get started. So I would hope that that not happen to any of our students. Thank you.
Dr. Marshall, I really appreciate that you shared that you're the director for that blog, because I don't know that everyone might have thought about really starting having your voice in maybe a brief or a shorter idea and build on that. That was such a great suggestion.
And it's so easy, and I'm happy to help, principally because I want to grow my blog. I want to grow my site. I'm working on that. And yes, it's a wonderful opportunity to be heard and to see yourself and to put it on your resume.
So I also appreciate that you're making yourself available. Students might want to think this over a little bit. And is it okay if we share your slides in the Commons also?
Oh, absolutely.
Okay.
And you can put my email in. this is my passion now, which is, you know, I'm part-time. I'm not going to be doing this ad infinitum, but I am very happy to help.
Thank you. So just to wrap up, I hope we'll continue the conversation in the Commons to keep the conversation going. It's the School of Health Sciences IPE Forum. If you haven't already joined that as one of your preferred groups, please do so. And just as a final thought, I'm hoping that this time works for everyone. I really appreciate all the faces that I see here tonight. Let us know in the Commons if the 6 p.m. Central Time is good for you, or if there's other times. And let us know if you have other ideas for topics that you'd like to see or any other feedback. We're really hoping to have more conversation in the IPE forum. So thank you so much to Dr. Marshall and our panel presenters, and for the great questions tonight. It's great to see everybody here. Thanks and have a good evening. Bye-bye.
Thank you.
Bye.